Hi, everyone. Welcome to today's Research America Alliance discussion. And thanks so much for joining today and for your partnership in Research America. If your organization isn't a member, you've heard me say this before, please do join us. We need, the power is in the number of people and organizations we have in our alliance. And I think Joel's email from our team is in the chat. Joel is the person to talk to about all things membership. So please do shoot him an email. Our special guest today is Rob Smith. He is the managing director at Capital Alpha Partners and a longtime source of counsel and insights for Research America. We've asked Rob to help us demystify the recently enacted Inflation Reduction Act, or IRA, and how it figures into the R&D landscape. As always, type your questions into the Q&A box or chat. Do engage during this discussion. I think that it's one where there will be questions that arise. And Rob, let me turn it over to you.
Great. Thanks so much, Ellie, and thanks for joining us, everybody. Really appreciate the opportunity to be able to speak with you guys today. Research America is just such a great organization. I've been friends with Ellie for a long time, and yeah, they're just so knowledgeable and so effective, and put out some really great content, and some of their thought leader programs as well. It's just it's a huge help to us, and yeah, just couldn't be happier to be here. We can go to the first slide. As advertised, here to talk about some of the drug pricing provisions in the IRA. If you think back to the beginning of when all this began, and we were talking about the Triple B, the Build Back Better Act, $1+ trillion worth of spending, just a huge entitlement expansion, and was on the line. And there were two elements in there. The drug pricing provision that was actually a bicameral agreement between House and Senate Democrats, and the ACA subsidy extension. And even when everything sort of went south, when Senator Manchin said that he was not on board with all the new spending and the Build Back Better Act, and the legislation had been declared dead sort of over and over again in various forums and forums. With Capital Alpha, we always said that that this is these two provisions, the drug pricing and the ACA subsidy extension, would that is essentially would be political malpractice if Democrats let their reconciliation opportunity slip away without at least acting on those two provisions. And lo and behold, it happened. And so here we are. So Capital Alpha, we provide advisory services to companies, investors, pretty much in about anybody and everybody in between. So it's been a lot of time sort of picking through the pieces of this bill, and that's sort of what came about with this presentation here. We think it's a kind of a simple way to look at all the various pieces and think about what might be ahead as far as implementation, and the various elements that we need to pay attention to as CMS and HHS get underway with putting this thing into motion. So there's really, as far as the drug pricing pieces of the IRA, there's really four main components. You have the drug negotiation piece that got most of the attention there. You have the Part D reforms, a lot of which were included in the bipartisan Senate Finance Committee drug pricing bill from last session. So we can talk through those two. You have, of course, the inflation caps on price increases that go into effect starting next year. And then you have the extended moratorium on the Trump rebate rule until 2032. That rule had already been put off. It's a bit of a budgetary gimmick that helps generate some savings. So that was included in this as well. And we can go to the next slide. You can see here sort of like a rough timeline for what provisions are going to be implemented when. So as I said, in 2023, you have the rebates that are required for drugs or for manufacturers that increase their product prices higher or at a faster rate than inflation. You have the $35 a month out-of-pocket cap for insulin under Medicare. Democrats originally wanted to apply that cap to commercial as well. That was stripped out, of course, during the parliamentarians' review. And then you have the elimination of cost sharing for adult vaccines under Part D. So, heading into 2024, you have the 5% beneficiary co-insurance for Part D catastrophic coverage is eliminated. And then you expand the income eligibility for the low income subsidies or that are available, or the Part D subsidies for the low income folks starting in 2024 as well. So, that 2023 to 2024 period is really I think what you're going to see Democrats really highlight heading into the 2024 presidential elections. You also, at least in name, have the start of the pricing process for the negotiation under Medicare. So that kicks off at the end of next year, but as you can see here, it's not until 2026 that those prices are actually applied. And I think that timeline there has a lot to do with some of the news that we heard from the Biden administration last week, as far as the executive order on drug pricing that they're going to pursue. HHS is supposed to deliver a list of, or CMS is supposed to deliver a list of recommendations within the next 90 days for what drug pricing demos that CMS could take up sort of in the interim period there. So that's going to be something to watch, and happy to talk about that later. And then, as you can see, sort of the pricing application ramps up sort of year by year, where you have 10 Medicare Part D drugs at first, then an additional 15 Part D, and then from then on it's 25 or 15, and then 20. It's not until 2028 that the pricing will actually apply to Part B drugs. So biologics get a little bit of a break there. And then you can see there on the right, as far as the implementation period for the Part D premium growth, and then the rebate rule that I mentioned before is there further on the right. So we can go on to the next slide. So I will fully admit, so there's two of us who principally cover healthcare at Capital Alpha Partners. You have myself, and then you have Kim Monk. And Kim happens to be the Part D and sort of plan expert at Capital Alpha Partners. So I know enough to be dangerous about Part D, but we can sort of go through this here. And this is a good illustration of how the various pieces and responsibilities shake out, from current law for the Part D benefit compared to the IRA changes that will be implemented, by 2025. And you can see there's a pretty substantial change as far as the amount that beneficiaries are responsible for and the plans are responsible for. And definitely happy to share this presentation with you guys. If anybody would like, just feel free to reach out to me or to Ellie, and we'll get that over to you. But you can see, I think this is a good visual representation of just how much of a pretty significant change it is to this benefit under this. And whereas a lot of the talk is about the negotiated pricing aspect, particularly on the manufacturer side, there's going to be a lot to this Part D redesign as well. So again, happy to share this with you guys after today's presentation. But you can go to the next slide. And you can see here, as far as the number of beneficiaries that will be impacted here, definitely in the millions. I think this is going to be a really politically popular piece. Kind of brings the question, if you see that Republicans, at least in the Senate, you have a handful that have launched this IRA repeal effort. So you look at the number of beneficiaries that are going to be, positively impacted here, just from the Part D redesign. That sort of, brings the question, the political wisdom of, setting off on trying to repeal this law. And I think that gives you a real, sense of how challenging it's going to be to make major legislative changes going forward, particularly to this Part D piece. So, I mean, the way that we've sort of characterized it is, Republican efforts to repeal the IRA drug pricing provisions are likely to meet somewhat of the same fate and be as sort of politically perilous as the ACA repeal efforts were during the Trump administration. So, I think for those hoping that this will all kind of go away, kind of doubt that's going to happen. I mean, if you look at again, how many beneficiaries will be positively impacted by it, and then the fact that the drug pricing provisions overall save over $100 billion. That makes it really difficult to repeal going forward, particularly as we're going into a period of when the debate's probably going to turn to Medicare insolvency. So repealing something that saves money is going to be pretty difficult. So yeah, you can see there too, as far as the number of folks who'd be positively affected by the insulin caps there as well. We can go forward from that. Yeah, so you can see here, government definitely on more of the hook for Part D expenses. We've kind of talked through some of this, all overall. Again, it does cost $25 billion. This piece of it, that gives you an example, or sort of an idea of exactly how kind of momentous this change is. But yeah, we can go forward to the next one. So I think that what folks will really want to talk about is more on sort of the negotiation side. So this just gives some more information about the Part D reforms and how that's going to affect both plans and manufacturers. I think we can go forward from there. Okay. So here we get to the inflation rebates, and this is, it sounds like a pretty straightforward provision, and at least for Part B, these inflation caps have been kicked around for upwards of a decade, and it's our understanding that really industry had put those on the table before in past drug pricing debates. The Part D rebates were included in the Senate Finance Committee bill from last session, so none of this is like particularly surprising. But there are a lot of things to consider here as far as the implementation dates and how they're applied different ways for Part B versus Part D. For Part B, these rebates will be due on a quarterly basis for any increases over CPIU. And then for Part D, these are going to be applied on an annual basis. And you can see there that really the first penalties aren't due for Part D increases until July 2024. It's kind of a convoluted way that provision was written. I think there's going to be some debate over exactly how some of these are applied. CMS still has to put out rules for how companies are supposed to report their various pricing information. And then the law actually includes some provisions that allows them to delay issuing that guidance. That doesn't mean that the application of the penalties or the time window for when those penalties would be assessed would change, but it does allow HHS CMS to sort of delay implementing guidance on this. So it could be that there some of this is a bit gray going forward until we actually get that actual guidance. You can see there are some exemptions. This drugs in shortage or with a high likelihood of being in shortage. That could be, an area that we could see some changes, or that, companies might seek to exploit going forward. You also have exemptions for vaccines. Part B, the 340B units are exempt right off the bat. And then, of course, units packaged with underlying service reimbursement. So like service, all the surgical drugs and what have you, those are exempt. And then for Part D, 340B units are exempted starting in 2026. And these rebates are paid on a per unit basis as far as what's sold to the Medicare program. So that's going to be having those exemptions in place is going to be key for some products. And you can see that there's a really pretty costly penalty for not playing ball with this.
Hey, Rob, can I interrupt with just to ask one question? So this doesn't affect beneficiary liability at all, does it?
No, I mean, I guess to the extent that, no, it really doesn't. I think you could see some trickle down to the D plans. You could see some, it might have some impact on rebates as well. But really, as far as direct impact, it's not that substantial. Okay. At least initially.
Thanks.
So yeah, and then you can see on the right there, I mean, as far as like perverse incentives here, I think it's kind of obvious that if you are going to put a cap on the rate of increase, that it would make sense for manufacturers to look at raising their initial prices. So I guess in that from that perspective, it could have kind of a negative impact on folks. And to the extent that it does limit ASP prices or ASP increases, I guess it could have some trickle down impact onto the overall program spending and thereby premiums. But yeah, really directly, not really. And then too, I mean, anytime you put a cap like this into place, I think that, manufacturers have to look at this and say, well, we've been increasing prices under inflation for however many years. And now the government is essentially saying, oh, it's okay. It's, inflationary price increases are cool. So
that's right. That you can at least increase at the inflation rate where some prices weren't changing necessarily. Right.
Yeah, exactly. Especially if you're going to get hit in other areas. That could be something that folks could certainly look for. So, yeah, you can see the benchmark there too. So yeah, I think we can go to the next slide. Okay, so this is the big one, the negotiation piece, and this has been really something that Democrats have been after for forever. Certainly, is I mean, since the Part D benefit was created, really, the ban on Medicare directly negotiating prices has been in place, and Democrats have wanted to do away with it. So they didn't quite completely get away with it, but here you have some exemptions or exceptions that allow the HHS to negotiate for certain drugs, and here's where we are. So as I said before, Part D drugs, the pricing for those or the negotiated pricing will apply for those products starting in 2026, but it's not until 2028 that you get the Part B drugs sort of folded into the mix here. And as far as when those drugs become eligible for negotiation, Part D drugs, they can be, you can start the negotiation process 7+ years after they've been on the market. The pricing won't apply till they've been on the market for 9 full years, but it's really you get 7 years before you could be brought into the fold at all. And then Part B again has an advantage in that they're not eligible for that process until like 11+ years, and it's not till 13 years that you could actually see pricing applied. So the number of drugs, as you can see in 2026, it starts off pretty small. In 2027, you add an additional 15 Part D drugs, so you get to 25 total. After that, you can add an additional additional 15 total drugs from Part D and or Part B. So that's when the Part B drugs can be folded in. So that's not 15 additional D and 15 additional B, it's 15 total. And then 2029 onward, they get to add 20 drugs per year. So, start small, but, over time that builds up pretty quickly. And I think that there's still a bit of debate out there as far as whether these numbers are cumulative. I know when this agreement was first issued, folks picked through it, and the thought was that it was 10 drugs, and then in 2027 it was 15 total drugs, and then 15 total drugs for 2028, and then it was 20 total drugs, not additive, not cumulative. But sort of over time, I think folks' interpretation of the legislation changed, and we were able to figure out, I think from some of the authorizing committees, that it was their intention to make those numbers cumulative. And I think you can talk about what might be able to be changed going forward, but I think that piece could still be open to some interpretation. It's obviously would have a huge effect depending.
Yeah, on Rob, I have a couple of questions on that. Number one, it says that HHS selects from the top 50. So are there going to be rules around how they pick those first 10 drugs beyond the fact that they need to be in that somewhere in that 50?
Yeah, good question. So it has to be Part D drugs.
Right.
You have the top 50 spend, right, but then you'll have drugs that are not eligible because they haven't been on the market long enough. So that's going to narrow down their choices. But other than that, I mean, HHS, they have pretty wide flexibility to sort of choose where they want to.
Wow.
I would assume that they would take, kind of the biggest
Utilization.
bang for their buck, at least
Yeah.
initially. But I think too that there's also going to be some gamesmanship there. You have to look at, drugs become ineligible once a generic or a biosimilar is introduced. I think you have to see sort of what the generic and biosimilar pathway or pipeline looks like. So if you pick a drug and it's only going to be on the list for
6 months or something. Yeah.
6 months, what have you, for generic, before a generic comes online, you're not getting that much savings there. Of course, in subsequent years you can add more drugs, but I think they have to be kind of pretty careful about how they go forward with that. There's a lot of factors that are going to go into place. I don't think it's going to be like straight up the top 10, drugs that have been on the market long enough. They're going to have to have some.
And is it assumed that these drugs will, the companies will allow to increase the price up to the inflation rate in the next year and the next year and the next year? Or is there a requirement that that price stays the same, the negotiated price stays the same?
Negotiated price is the negotiated price, yeah.
Wow, so there's no increase permitted.
Yeah.
Not that, okay.
Yeah.
Okay.
Yeah, so that's going to be interesting. And I think that too, that's a great question, because it sort of points out how all these various things are going to interact, right? So I think that could be something that needs to be spelled out in law. And I think, you look at other exemptions that might be in play too, that the law might mention, but they don't have specific language around. And I'm getting a little bit ahead of the presentation here, but we get a lot of questions about, reformulations of products. Like
Right.
there's one, if you have an injectable product that you then reformulate as a subcutaneous injection, and then you file a separate BLA for that, does that get you exempt? Do you get, do you start over the clock on that drug for that BLA? So I think you're going to see some really kind of sophisticated, consideration and, gamesmanship, if you will, around how this is implemented and how this is applied, particularly, as we get guidance and rules around this. Because I think once those are out there, then that sort of gives you, a good sense of the battlefield, if you will, as far as like how you can sort of move your various products around. And
well, that raises one more question in my mind, and that has to do with new indications, right? So with cancer drugs, actually, the research that goes into new indications, and it attends to other drugs also, but for cancer drugs, that's crucial to progress, right?
Yeah.
So are new indications subsumed under the same pricing, the same price?
I think that's going to have, I think that's the way that, like, if you take like a plain reading of the law, but again, like it's going to take some guidance and some regulations around how you handle each specific. I think it's going to be like a case by case kind of thing.
Wow.
And then, you also get to negotiate with HHS. I mean, this is going to be like a whole new area of lobbying, right? Where, you go in and you plead your case with HHS why you shouldn't be selected. And there's
what the cap should be, really, which is, I guess, what it comes down to, right?
Yeah.
That's negotiation is what the cap is.
Exactly.
Wow.
Exactly. And then you can see here on the right, as far as like, what is the negotiated price? I mean, it's called negotiation, but it's really pricing caps. You can see how those caps work. Kind of, it's all based on how long a drug has been on the market. They create a couple of different classes of drugs as far as like long monopoly, like super long monopoly. But right there, I don't think we need to read through that. But I mean, you can see the discount goes from 25% to 35% to 60% for those drugs that have been on the market, 16 plus years. So pretty substantial change. But again, like absolute, there's going to be such a great niche lobbying market for this. It's going to be fascinating to watch. We can go to the next slide. And then, as far as the timeline, as I mentioned earlier, for the 2026 pricing year, it's a bit of an anomaly because, this, at least the negotiation eligibility sort of selection, that's going to start in 2023, so 3 years ahead of the pricing application. But really for 2027, that I think that's, we should think of as like the first normal year. All of this is going to take place, 2 years prior to the pricing year. So again, I'm not going to read through the 2026 pricing thing, but you can see there for 2027 onward, February 1st, so 2025, you're going to get the list of eligible drugs published. You have the negotiation agreement deadline of November 1st of 2025, November 30th, you actually get the maximum fair prices published for those drugs. And it's going to be, November 30th of 2024 when you get, the first 2026 pricing published. So a lot of lead up to that. Could be that some of this changes between now and then, but I think I'd pretty much count on, at least for 2026, for that to be sort of the schedule that they follow. We can go to the next question. We touched on this a little bit as far as, exemptions. It's kind of interesting. I think that if there was one group that did well here, it was probably, biosimilars, and that they were able to you have the exemption one tied to the, introduction of a biosimilar. So that's going to be interesting. And then they have this provision in here as far as the high likelihood of a biosimilar coming online in the next 2 years. So if you're a Part B drug and you would otherwise be selected for the 2029 price negotiation application, if you could demonstrate that there's a high likelihood that a biosimilar is coming online in those next 2 years, you could be exempted. HHS has the ability to follow up on that and say, hey, well, it turns out that that's not going to happen. So, here's your pricing cut. But there is an exemption for that high likelihood sort of piece there. So I think it's pretty interesting. And then also to note, this isn't, I don't know if I mentioned this here, but there's also an initial boost to ASP +6 for biosimilars to ASP +8 for new biosimilars. So that's pretty interesting as well. You can see there is a carve out for small biotech drugs. I think that was pretty an instrumental piece in having some of the Democrats who had been sort of reluctant to proceed with drug pricing in the past. Especially I think there were some California members that were really concerned there with some of the small biotechs out there. So you can see that there's a bit of a temporary exemption for small biotech drugs. Orphan drugs with one indication, we touched on that a bit. Vaccines marketed for 13 plus years are also exempt. There've been some earlier reads that all vaccines were exempt, but it's only those that have been on the market for 13 plus years. I'm not sure exactly what they're trying to capture there. I'd imagine it's mostly Shingrix, but we'll see. And then biologics derived from human whole blood or plasma. And then you can see this is a real key point here is the penalties for not playing ball. Really, the way that CBO has looked at this in drug pricing structures in the past has been, essentially to come back to, the proponents of whatever approach and say, if we're going to give you a good score here, you have to apply some absolutely ridiculous excise tax to ensure that people actually play ball. So Democrats, of course, applied a ridiculous excise tax to this. You can see there you face, upwards of a 95% penalty on for any drugs that revenues for any drugs that if you don't play ball with negotiation. And not only that, manufacturers who refuse to pay the tax or refuse to engage in negotiations can face the loss of Medicare coverage for all of their drugs, not just the negotiated drugs. And then sort of as a backup here too, there was some thought that the excise tax was not going to fly with a parliamentarian because CBO, even though they said they wanted a ridiculous excise tax, they also decided that this tax was so steep that nobody would end up paying it. It would be better just to discontinue selling your drug than to go forward with a 95% penalty. So it scored zero revenue. So there's some thought that this parliamentarian would not allow it under Byrd rules. But they did allow it. So you have an excise tax and the civil monetary penalty. I think the civil monetary penalty was sort of a backup in case the excise tax got axed. You can see there that there's also that huge civil monetary penalty that's in play too if you don't play ball. So we can go to the next slide. And this is just, a bit of blue sky kind of spitballing. I'm sure you could add a ton of factors to this, or a ton of questions here. But there's just some things to think about. It's really kind of the negotiation structure. What's that going to look like? And how are different administrations going to interpret this law? I mean, you have some Hill Republicans saying it should be completely repealed. So it could be that you have a different read of these different provisions, going forward, and particularly since the bulk of this doesn't really apply till 2026. That gives pretty good leeway to get some changes done. Should we have a change in administration or change in political party in the administration? And then I think court challenges. I'm sure that pharma is going to overturn every stone that it can to launch legal challenges. I mean, you have the 8th Amendment takings clause. I think that was a lot of that is kind of like applied on, or meant to apply to like prisoners and that kind of thing. But, certainly it could come into play here. There's some, companies have the ability to challenge excessive government fees. And then, it's going to, as I said before, it's going to be a big lobbying game too, where manufacturers can certainly come in and argue to HHS and CMS that they shouldn't, have this structure applied to them. Industry reaction, definitely, you've seen a lot of folks on the industry side saying that this is like a death knell for innovation, but, kind of remains to be seen exactly, how that's going to trickle down, how it's actually going to impact investment, how, truly, the level of change this is going to bring about. So I think you're going to have some shifts there. And, I think a lot of it's going to be maybe you have different strategies about where you launch your products and when. Perhaps there'll be other countries that will get certain drugs first instead of the US sort of being the leader there. So that's going to be really interesting to watch going forward. And then, as I mentioned, I mean, I think there had been some thought from the policy community and certainly industry that, okay, so we get the IRA passed, and that's obviously not great for pharma, but perhaps that will give us some breathing room, on the legislative side and from CMMI. But then, of course, lo and behold, last Friday, the White House issued this executive order saying that it's going to pursue these CMMI demos. So that's going to be interesting to watch. I think that they can't do anything super substantive and disruptive there, just for fear of sort of getting sideways with some of this IRA provisions that are going to be very complex to implement. But we'll see what happens there. And then we can sort of read through the rest of that. But Ellie, I think I've gone over my time a little bit, so maybe I'll just turn it back to you and see if we have any questions from the audience.
That's great. And, thank you so much, Rob. One of our goals today was a presentation that, didn't have a particular point of view. And that's very, very hard, I think, with this legislation, because even when you're trying to explain, as I was doing in answer to a question, what the implications are, the language you use becomes very tricky, and so I really appreciate the presentation you just made, because I think to the extent anyone could do it, you gave a very objective look at this legislation. And before we turn to audience questions, I had a question about the implications of the president's executive order. So I think that you explained that what actually the ask was, or the demand was in the executive order, is that CMS look at what kind of demonstration projects it could do through CMMI, which stands for the Centers for Medicare and Medicaid Innovation. Is that right?
Yep.
Beautiful. That was established actually under the ACA, under the Universal Coverage Bill passed back in 2011, I believe. So could you give us a sense of what a demonstration, there may have already been these demonstrations, but just an example, what could a demonstration look like?
Yeah. Yeah, and I think you'll probably get maybe a multifaceted approach from CMMI. I mean, as you guys know, Liz Fowler, industry, Hill administration veteran, is she's the director of CMMI, very politically and politically savvy and probably
policy genius,
best policy experts.
tries to do good all
Yeah.
the time through
Yeah.
the political system, which is not easy all the time.
No, exactly. So I mean, if somebody can get something off the ground here, it's she is one of like probably the top handful of folks that could get something done. And then I think too that from a leadership perspective outside of CMMI, I think Dora Hughes has been tapped with kind of running point on this as well. So right there you have two tremendously talented individuals who are going to be kind of responsible for this. For CMMI, it is a tremendously powerful tool that gives the administration a lot of flexibility to test, all kinds of demos. And we've seen, the ACO REACH, direct contracting, the various other, the oncology care model, various other demos, all the bundling, whatnot. So they can take a pretty broad approach. And, under the Trump administration, he saw it as a real sort of like weapon against pharma. And, you saw the, what was it? The International Pricing Index.
That's right.
And then the Most Favored Nations program that was just kind of like a follow-on of that IPI that of course got shot down in court. But that was would have been a hugely disruptive model that would have been really punitive for pharma. So I don't think we're going to get anything huge like that. I think probably what we're going to see is something like pricing caps. They've talked a lot about how the insulin caps could be an interesting approach to apply in other areas where you have a population of folks who take a lot of a particular medication that happens to be expensive, and you could probably come up with all kinds of options there. And I think too that they're probably going to take credit for some stuff that's happening already. Mm-hmm. So you have the enhanced oncology model, the EOM. It's really kind of like a retooling of that oncology care model that has a very big pharmaceutical component to it. They actually mentioned that in the executive order. So I could see, as that gets off the ground starting next year, that could be something that they'd really point to.
That makes sense.
So I think it's more stuff like that. I don't think you're going to see like a total disruption of like, the way that Part B drugs are reimbursed and distributed.
I see. It's more like integrated care models and that kind of thing that include the drug reimbursement as part of that package.
Exactly. Like how could you add like Part D plan expenditures to like the ACO REACH model, like that kind of thing.
Okay, that's really a good picture of what we might see. And so Dwayne has a great question. Short of repeal, what tweaks to the IRA are possible in the next year or the next Congress? And that's not an easy question.
Yeah, that's a good question. And the next, I think that the real game is going to be at the regulatory level here for now.
Not statutory change.
Yeah, I think, we have exactly, 0 regs from, what's going to be thousands and thousands of pages of, how you actually implement this. The IRA puts together a pretty good blueprint, but didn't actually build the house, and it's going to be up to, CMS to sort of put all this together. So that's going to be interesting. And I think there is a provision in this that I hadn't seen in too many other pieces of legislation that kind of makes clear that CMS can implement some of this using sub-regulatory guidance.
Oof.
Which isn't subject to notice and comment like you'd usually see with legislation like this. So that's going to be really something though to watch. And I don't know how exactly they'll apply that, but that gives them a lot of leeway for how they proceed with this. So definitely,
that's really important.
Yeah, put that in the back of your mind. But I think from a legislative perspective, if we end up with at least a divided Congress, like some folks are saying, or that seems to be consensus that Democrats will probably lose the House, could lose the Senate. There's going to be some stuff that they'll have to do, around maybe extending some of the PHE flexibilities, that kind of stuff, depending on what happened. In lame duck, they're going to have to do government funding bills, but I think anything that you see, particular to the IRA, at least for the next session of Congress, would be political messaging, not really changes.
I think I think that for folks in the audience, regardless how you feel about the IRA, it's going to affect access and investment in innovation in ways that are really hard to tell. But there's no question that it's relevant to those of us who care about making sure patients have access to medicines that are affordable, and also that medicines keep being produced. And what this speaks to me, the fact that we may not have public comment period for all of the decisions, is that having your questions, out there in the public eye and asking for transparency and notice is going to be really important for all the decisions around this for anyone who cares about medical progress and about affordability. So it looks like we have another. No, that was Dwayne's question. Hey, Sarah or Sam, whoever is helping out here with questions. Do we have other audience questions that I'm not seeing?
I think that's the only other question that's come through that hasn't been answered yet.
Cool. Does anyone have a question that they haven't typed out and want us to unmute you? I can ask questions all day. We only have about 3 minutes of Rob's time left, but
so we actually did just get another one.
Oh, wonderful.
So Rob, how do you think gene therapy will be factored into negotiations?
Great question.
Good question. I think we'll have a while for that to play out, just since these are so new, and the product has to be on the market for so long before it can actually be have that negotiation structure applied. So I think a lot of that's going to be TBD. I think there's going to be some questions is like, how effective is it too? I mean, it could be that HHS again has a pretty good flexibility as far as like what they are able to choose from. So I think even, when those products do become eligible for negotiation, that, it could be that they would pick something else. But that's not to say that you couldn't see other changes around there. So back to the whole CMMI thing, one of the things that they talk about is implementing value-based purchasing programs for certain drugs. Certainly you could see CMMI used in that way. I mean, people have been talking about, doing that for a decade. We haven't really seen much in that environment, but again, you put some smart folks together who are able to figure out how to implement something like that. That could be something that you see.
It's so true. And the other thing is, once you have a blueprint in law of a certain way of doing things and it gets fleshed out, it becomes a precedent that can be used and expanded over time. So that's another reason to kind of watch this very carefully and weigh in to the extent you can. And Rob, I have a question for you that please don't feel obligated to say yes to this, but we've gotten several requests for your presentation. Is that public record, or is that proprietary to Capital Alpha?
It is proprietary, but yeah, happy to share it with you guys. Yeah, for friends and family. So
oh, you are an angel. And you are an angel for joining us today. You've been generous with your time. You've explained this in a way that I never ever could, and I don't know if anyone on our team would be able to, but I certainly couldn't. So thank you, and that we'll be calling on you again.
Yeah, anytime. Always love speaking with you guys, and yeah, happy to chat anytime.
Wonderful. And hey, Sam, could you go into our what we're next week's Alliance discussion, etc.?
Absolutely. Thank you again, Rob. And we hope that you can join us next week on October 27th, which is a Thursday at 3 p.m. We're going to be joined by Dr. Dylan George, who is the Director of Operations for the Center of Forecasting and Outbreak Analytics at CDC. And it plans to be a very interesting conversation. So
yeah, so he's really, that team is tracking pandemic's future and present. So I think it's going to be really interesting. And we have other upcoming discussions around what's going on with vaccine development after and during COVID. Lots of good discussions to come. So keep an eye on your emails from us and join us next week.
Yes. Thank you all so much.